All right, I'm all set with the updated note, and we want to thank WHO in advance for on short notice joining us. So I guess it's good afternoon to almost everybody, but good morning to folks on the West Coast, and it's almost good evening for our speakers. My name is Sten Vermund. I chair this Committee on Prevention and Control of Sexually Transmitted Infections in the United States. This is a committee of the National Academies of Sciences, Engineering, and Medicine, and the project is sponsored by the U.S. Centers for Disease Control and Prevention through the National Association of County and City Health Officials. So I'm joined by most of my fellow committee members who are also participating in this meeting virtually. All of the committee members' names, affiliations, and biosketches are available on the project website, which is just www.nationalacademies.org/prevent-STIs. Any questions can be emailed to stiprevention@nas.edu. So before we get further along, this is an open, on-the-record session. Interested individuals have been invited to attend virtually as observers. I'd like to remind everyone that this is information gathering only. The committee is in the process of assembling materials that it will examine and discuss in the course of making its findings, conclusions, and recommendations. So everyone, please be very mindful of the fact that the committee has made no conclusions, and it would be a mistake to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee nor of the National Academies of Sciences, Engineering, and Medicine. In addition, community members typically ask probing questions in these information gathering sessions, and this may or may not be indicative of their personal views. The committee has been and will continue to deliberate thoroughly as it writes its draft report. Once the draft report is written, it has to go through rigorous review by experts who are anonymous to the committee. This virtual panel that we're assembled today includes presentations and discussions on topics to fulfill the committee's information gathering needs. In addition to the presentations that we will hear today, the committee has reviewed information relevant to its charge from many sources and will continue to gather additional information over the course of the study. For the record, speakers will be asked to disclose whether they receive any funding for activities related to the topics being discussed today and the sources of this funding, if any, for example, government agency or foundation funding. The meeting is being recorded. Available speaker presentation slides and videos will be posted to the project website within 2 weeks after the meeting. Now I would like to introduce our first speaker, Dr. Janet Wilson. Dr. Wilson is president of the International Union Against Sexually Transmitted Infections, other affectionately known to many of us as IUSTI. Committee members, please hold your questions for Dr. Wilson until after all the speakers have presented. We'll have Q&A with all the speakers after they've presented. So Dr. Wilson, please feel free to start your presentation when you're ready. Thank you.
Okay, thank you, Amy. Oh, thank you, Amy. So I would like to thank the committee for inviting me. It's a great privilege to have this opportunity. I wish to make it clear I am no expert in STI prevention and control, but as you acknowledge, I do have this role as an international, as the president of the International Union of STI. A little bit about my background: I'm a clinician. I work in Leeds, which is in the northern part of England. We have a population of about 1 million people, and we have a high college attendee number of about 70,000. Can I have my next slide, please? Amy, thank you. And these are my disclosures. I received some government-funded, UK government-funded grants, and I've received research grants and participated in research trials of diagnostic and pharmaceutical companies, and received a consultancy fee from a pharmaceutical company. Next slide, please. So what are we aspiring to? I think it's good idea to start from the beginning. Well, in 2015, the United Nations resolution of transforming our world had a 2030 agenda for sustainable development, and that included, in Goal 3, ensuring healthy lives and promoting well-being for all ages. And in response to that, the WHO developed 3 global strategies on HIV, viral hepatitis, and STIs. Next slide, please. And all 3 of these strategies highlight the policies and systems that deliver integrated health interventions and services. So I'm sort of emphasising the integrated. And these should be adapted to different populations and provided at different locations to achieve equitable and quality care. With, of course, the aim to reduce infections and their related morbidity, mortality, and improve the sexual health and well-being of all people. Next slide, please. So what might equitable and quality healthcare look like? So I've put together this sort of slide of really, I think, what are the 4 components of quality sexual health. And that starts with potentially an HIV service, with early diagnosis and access to antiretrovirals, universal access to antiretroviral drugs, adherence support and partner notification. Our STI aspect of it should include, obviously, asymptomatic detection, as well as symptomatic care, with targeted services for those who are higher risk or more vulnerable, such as adolescents, sex workers, men who have sex with men, and trans people. And then we move on to the sort of bridge between STI services and prevention, of contact tracing, prevention techniques such as condom provision and vaccination of hepatitis and HPV, and prevention of HIV through PrEP. Other prevention changes, which are behavioural interventions, and also drug and alcohol addiction services. And then lastly, our reproductive health services of contraception, cervical cancer screening, and antenatal screening for HIV, STIs, and hepatitis B. Next slide, please. So how can we deliver these aspects of care, and how are they delivered throughout the world? Well, there are many different models of there are many different models of delivery throughout the world. And there's no model that fits all, but maybe that some are better than others. And I think how those models have developed is really dependent on how STI and HIV services were set up in the first place, and any integration that's happened of those. So if we look at Europe and much of Asia, the STI services are predominantly delivered by dermatovenereologists, or female sexual health services may be delivered by gynecologists. But the HIV care is delivered by infectious diseases specialists. In Southern Africa, again, there are split services, and that has mainly been driven by the NGO donor priorities, with a lot of money being given to HIV, but really very little being given to STIs. But there are some successes throughout the world which we could learn from, and the 2 I've got examples from are from middle income countries. So in Morocco, they have separate STI and HIV clinics, but they run parallel. They're co-located and they run in parallel. And so the staff are trained in both of the services, and it's very easy for patients attending those services to get both STI and HIV care in one visit. And in Peru, the HIV and STI services are also combined, run by the Ministry of Health, and they were set up in conjunction right from the start. And they have been very successful at keeping both STIs and particularly HIV prevalence low. Next slide, please. In the UK, we have combined STI, contraception and HIV services, and all of these are free at the point of care. Australia also has combined HIV and STI services, but some payments, some services are paid for, and for instance, PrEP is paid for. So you mentioned about the other kind of services that may be delivered, and I was thinking, well, what kind of services might they be? And I guess they are potentially self-care. And why would someone choose self-care for their STI rather than going to an established service? Well, I guess that's only likely to happen when the provision of the service is too scarce or too expensive for them. And it's likely those people would go to online or pharmacies for purchasing treatments. Ideally, they would do it with testing, but I suspect if that increased the cost, it's just literally purchasing the treatment. And although some of these testing and treatment services may have links to public health or healthcare services, a lot will not. I know of some cases of services selling point-of-care tests with very poor diagnostic accuracy, which are neither European or FDA approved because of their poor accuracy. And the selling of treatment is based purely on syndromic management. And of course, there's no follow-up and contact tracing. So that is, of course, what we do want to avoid. So really the most effective form of service is an adequate provision of an accessible and affordable STI service. Next slide, please. So what are the barriers to providing good service? Well, I've already mentioned about the NGOs, but of course governments do the same. So government, NGO and donor policies are driving separate services by different funding streams, and HIV given the priority of the funding. But that's not just within the government and the funders. I think there's silo thinking in the providers of HIV and STI and contraceptive care, and thinking purely about the kind of service I feel comfortable delivering, rather than necessarily what the patient would like, or developing a patient-centered integrated service. I think there are issues with funding and reimbursement systems and not covering the whole package. I could be wrong here, but I do recall at some conferences people from the US saying that some health insurance schemes only cover 1 NAT per year, which is clearly inadequate for men who have sex with men, where the minimum they should have is triple site testing, ideally twice a year, and in the UK we would say 4 times a year. And of course we must remember that those affected by STIs are often the least able to supplement their health financially. I've also, I think, attitudes are barriers to care. In some parts of Africa, of course, it's not just attitudes, it's legislation that affect MSM care. That's not an issue for the US, but some in parts of the US, there may be services provided that are not so friendly towards MSM, and of course that's going to affect MSM wanting to attend those services. And lastly, the biggest barrier, I think, is that we lack accurate and affordable point-of-care tests for STIs. We need those because we want to reduce the period of infectiousness, and ideally when people attend a service, we want to give them the diagnosis and start them on treatment that same day. Next slide, please. So what are the opportunities? Well, I think we can break down those silos, and hopefully some of the funding that has supported the HIV can help the funding of the STI services, which have been underfunded and undervalued. And I think now is a great opportunity, because I think PrEP services bridge the STI and HIV services perfectly. People accessing PrEP need regular STI testing, but they also need long-term follow-up for taking their ARVs, which is normally provided by an STI service. I think we can improve integration of STI, HIV and contraceptive or reproductive health for people, because that will improve the STI screening and the reproductive health of people living with HIV. I mean, if you were to ask women who are living with HIV, are they happy going to one clinic for their HIV and their antiretroviral drugs, and then going off to another clinic to get their STI screen, another to get their contraceptive service, and then another one to get their pap smear? No, of course not. They would much prefer that that was all provided in one sitting. And I think we can increase our access to testing and care by changing our delivery of care. And the one thing that this pandemic has made us do is sort of modernise our services extremely quickly. So I guess all of us now are involved in a great deal of telemedicine or telephone consultations, and delivering, sending out STI testing and medication to people without actually seeing them face to face. And I doubt that we will go back to completely face to face consultations after this. Next slide, please. So what would be a good model of care? Some of you may be familiar with the Dean Street Clinic, which is in London. It's in the Soho, which is a very sort of diverse and active part of London. And it was a really very innovative clinic that tried to sort of tick all the boxes of people who, for people who might want to access it. So if you look, you can see it provides STI and HIV testing, contraception, HIV services, HIV post-exposure prophylaxis, HIV pre-exposure prophylaxis. It has services for trans community. It has a clinic for people who are addicted to drugs for chemsex. It has psychosexual support, under 18s clinics. So it pretty much encompasses everything that makes up a good delivery of sexual health services. Next slide, please. It's particularly been particularly attractive to young MSM who have high numbers of partners, and they've been able to access initially PEP and now PrEP from that. And those that, this is the group that were at very high risk of seroconversion. Their regular STI testing, done 3 monthly, meant that their HIV infections were picked up very quickly. So they were started on antiretroviral drugs. Their HIV became undetectable and they were then untransmissible. So all of this, plus it happening elsewhere in other clinics, really drove down the HIV incidence that we've now seen in the UK, as you can see in the graph. Next slide, please. Other innovations, which I've just put because it's what we do, but I know that they happen elsewhere and I know they happen in the US, is providing outreach teams to high risk and hard to reach and vulnerable groups of people, where we provide asymptomatic screening, vaccination, and if it's female service, contraception. So our outreach services go to the MSM support and advocacy groups, and sex on-site venues, and likewise to the female sex worker groups and venues, and even on-street vans go out to the on-street sex workers. Teams go out to the drug and alcohol addiction services and also to the homeless. And to improve access for the adolescents, we have drop-in clinics after sort of school hours between 3:30 and 5:30 for the under 18s. People are using now contact tracing through apps. That's particularly popular with the MSM. And although expedited partner therapy is not allowed in the UK, there are some trials using that to see, and I know again that's something that's happened in certain states in the US. Next slide, please. From the point of view of something that works really well, that's our infectious diseases screening in pregnancy. And just like with you, we screen for HIV, syphilis and hepatitis. And as you can see, our screening rates are incredibly high, almost 100%. And that's because it's an opt-out service. We have dedicated midwives who have knowledge of these infections, are very able to explain the benefits to the women of having these tests. We have multidisciplinary teams that manage the care of the women with the infections. And I have to say that the management of syphilis in pregnancy in the UK has benefited from these joint multidisciplinary team meetings. A lot of money has been invested into mother-to-child transmission for HIV, and we have been able to tap into that for both syphilis and hepatitis B. And our cases of congenital syphilis are extremely low. Next slide, please. And those of you who have heard me speak before know that this is an absolute passion of mine. This is a case I quote that was back in 2004, but is still applicable today. So a mother in Haiti seeks prenatal care. After testing for HIV, she takes ART for prevention to mother-to-child transmission. Postpartum, her baby is given ART and she provides artificial milk to protect transmission through breastfeeding. Is this a success story for the prevention of mother-to-child transmission? Well, it is for HIV, but no, the baby died at 3 weeks from congenital syphilis, emphasizing the importance of bringing those two things together. Next slide, please. Next slide, please. Sorry. So in summary, I think we need accessible and affordable, either the way it's done in the UK, so it's free at the point of delivery, or if it's to be paid for, affordable through a system that everybody can access that service without having to supplement it. And services that people want to use. There's clearly no magic formula. We need to provide multiple and innovative modes of delivery to suit the different groups. But we need to know what those patients want. We need to provide patient-centered rather than funder or provider-centered services that offer most of the care that people want, ideally in one visit. And I personally feel to succeed in this way, we need to break down those barriers between the currently sort of silo delivery of STI, HIV and reproductive health care. Thank you.
Thank you very much. That was just what we were looking for, to put it bluntly. We are looking for an international perspective to bring us out of our United States bubble. And you were very articulate on the integration issues, the services issues, removing the payment barriers. So that was just terrific. And now we're going to hear from Dr. Henry de Vries. He works at the Department of Infectious Diseases at the Public Health Service in Amsterdam in the Netherlands. And Dr. de Vries was highly recommended to us as someone who would have perspectives on optimization of STD services, regardless of where they might be. And of course, the Dutch programs have been quite successful in comparison to American programs. So Dr. de Vries, please feel free to start when you're ready.
Thank you very much. Let me see, I will share my screen. Yes, can you see my screen?
I can, yes.
Okay. Well, first of all, thank you for giving me this opportunity to share some of the thoughts I expressed at a meeting last December at World AIDS Day for a Dutch audience. And I was asked to give my opinion on how I see Dutch STD control in the coming 10 years. I'm a dermatologist, as was already mentioned, and I work at a large STI outpatient clinic in Amsterdam, where we offer free of charge STI screening, pre-exposure prophylaxis provision, and also sexual health needs, like, for example, contraceptives. So as a disclosure, I have two from private companies. Gilead, first of all, we receive medication and funding for a PrEP cohort study, and also Merck, Sharp and Dome, who provided us with HPV vaccination for a clinical trial that we have performed in the last few years. I will first mention the goals of the action plan, which was established in 2017 for STI, HIV and sexual health promotion. It's a 5-year plan. And with that, I will move on to the test and treat paradigm for STDs, which is currently the most applied paradigm, as I think. And I will plead for moving from secondary prevention towards primary prevention more, or maybe focus more on primary prevention, as secondary prevention is now in many places a mainstay. And I will conclude with imminent antibiotics shortages, which could affect STD control for the coming years. First of all, where do we stand in the Netherlands as far as the 1990 paradigm, the continuum of HIV care, where it is promoted also by WHO to have at least 90% of those living with HIV having their diagnosis, and then 90% of that proportion on antiretroviral therapy, and that proportion should have 90% viral suppression. We're doing a good job. These are the figures from 2018. On the left side, you see the total population estimations, where we exceed the 1990 goals. And the same applies also for men who have sex with men, which you can see on the right panel. And this is also what we see in STD clinics throughout the country. The data are aggregated each year. And these are the figures up until 2019. On the right side, you see that in the purple bars and also the purple graph show you the MSM, the number of tests that have been performed in men who have sex with men in the bars. And then the line indicates the positivity rate. And we've dropped from 2% in 2010 to below 0.5%. The information for heterosexual men and women was already low throughout the last 10 years, as you can see. So the HIV goals as formulated in the National Action Plan state 0 AIDS death by 2022, an annual number of new HIV diagnoses which should be halved, and the index is 900 in 2015. And 95 goals should be reached at that point. And we're doing a good job in that respect, which could lead to the elimination of new HIV infections in the Netherlands at the moment. But the question is, can we also apply this to the elimination of sexually transmitted diseases? And these are some slides that I found on the internet on the plans formulated by the CDC in 2000, where it was made feasible that elimination of syphilis was something to strive for. Around that time, there were almost 6,000 US cases of primary and secondary syphilis. And it was believed that it was an ideal moment to eliminate syphilis. Syphilis doesn't have an animal reservoir. It has a long incubation period, which allows treatment before transmission. There's a very good treatment, of course. And in other industrialized nations, syphilis was believed to have been eliminated. Of course, this all didn't come out. Syphilis is on the rise again. especially in a key population like men who have sex with men throughout the Western world. So what did the National Action Plan in the Netherlands formulate as far as syphilis and gonorrhea? Halving of the number of syphilis infections to 500, and also halving the number of new gonorrhea infections. In gray, you see the other goals that have been formulated, but I won't go into that. And the question is this a realistic goal to achieve as far as bacterial STDs are concerned? Well, here you see the positivity rates for syphilis and gonorrhea. On the left panel, you see infectious syphilis, and here the data on men who have sex with men are indicated in green, and in heterosexual women in blue, and in heterosexual men in red. And you see a stable positivity rate, especially in the MSM population. And although the number of testings are dramatically increasing in the last 10 years, you see that it has no effect on the percentage of syphilis that we diagnose. And the same applies also for gonorrhea, which you see on the right plane. Again, you see an increasing number of testing, especially in men who have sex with men, and we also see increasing positivity rate. The positivity rate for gonorrhea in heterosexual populations is stable around 2%, whereas in men who have sex with men, we are reaching now towards 12%. This applies for individuals who have been tested in STD clinics, of course. So why do HIV ambitions as formulated seem feasible as far as the elimination of new infection, but for bacterial STD, they do not seem to apply? Well, one of the things that is, of course, without doubt, is that HIV you can only get once, whereas bacterial STDs after treatment or spontaneous resolution can be achieved again when you are exposed. HIV is in many settings, and this is also applies to for the Netherlands, a focused epidemic within the key population of men who have sex with men. Condom use protects against HIV, but much less effective against bacterial STDs. And there are biomedical prevention interventions now available for HIV, which are very effective. Treatment as prevention, which rests on the paradigm that if you have an undetectable viral load due to antiviral treatment, you are not infective as far as HIV is concerned for your partners. And of course, what was already mentioned also by Janet, pre-exposure prophylaxis. We do not have these kind of biomedical prevention interventions for the other bacterial STDs. There have been some trials going on, for example, in France, where they tried doxycycline, continuous doxycycline usage, to see if it could prevent syphilis infections in men who have sex with men, who also use pre-exposure prophylaxis for HIV. And of course, bacterial antimicrobial drugs have many side effects, and the biggest problem, of course, is the induction of antibiotic resistance. So as far as now, in many cases in STD settings, it's testing for bacterial STDs. And does it work? If you look at chlamydia, for example, you see here a graph from the STD Commission, which appeared in Lancet Infectious Disease in 2017. You see many Western countries where you see a decrease in pelvic inflammatory diseases diagnosis in hospital admitted women. And you see impressive results, for example, in Australia, a drop, and in many other countries. But there are also countries in this graph who have no chlamydia control program in place at all. For example, Ireland, Belgium, and also Slovenia. And also in these countries, you see a 30% decrease in pelvic inflammatory disease, even without chlamydia screening efforts. So clearly there is something else going on, and it might be that chlamydia doesn't explain the whole picture of these outcomes, which are strive to be prevented through screening of asymptomatic chlamydia infections and treating these infections. So the test and treat paradigm for HIV is very effective, and this is also because 90% of the people who contract HIV will eventually fall ill. But this doesn't apply, for example, for chlamydia, where less than 1% of the women who are infected will become infertile or develop pelvic inflammatory disease. So the numbers needed to treat in the case of chlamydia, but also other bacterial infections, is far more far higher than is the case for HIV. And then antibiotic resistance due to antimicrobial antibiotic overconsumption is another a downside of testing of asymptomatic infections. And we might reconsider that we are fighting asymptomatic infection where we should fight infectious diseases. Here you see 4 graphs of antibiotic consumption in various European countries on the x-axis for cephalosporins on the top 2 tables, and macrolide and fluoroquinolone on the down 2 tables. And they are projected against the MIC, which is a level for antimicrobial susceptibility in gonorrhea, for cefixime and ceftriaxones, which are both cephalosporins. And you see a high correlation in countries with high consumption of these antibiotics and the effect on ceftriaxone and cefixime resistance in gonorrhea. And this also applies to macrolides and to fluoroquinolones. This is a graph you probably have seen before, where you see the threat of emerging untreatable gonorrhea, where we had 3 different antibiotic classes available which were effective to treat gonorrhea. We are now facing a period where the last resort medication, cephalosporin, might become resistant, and it will bring us back to the time before the antibiotic drugs became available. So we could reevaluate the testing and treatment paradigm. Should we detect and treat asymptomatic chlamydia infections in all cases? And there are runners-up pathogens, for example, Mycoplasma genitalium infections, which has the tendency to contract antimicrobial resistance very easy and will lead to a lot more consumption of antibiotics. Should we keep on treating on complaints only? For example, men with urethritis symptoms are now treated with azithromycin or doxycycline before we know if there is a pathogen involved in the complaints? Or should we better wait for 24 hours, which takes it now before nucleic acid amplification tests results become available, and then focus on those who should be treated with an antibiotic? And the same applies for partner notification. If we know that 1 in 3 of the patients, the partners, do not require treatment because they haven't contracted the infection from their partners. So that's why we should look for the coming 10 years, not so much on the detection of infections, but on the prevention of infections. And we are in a time period where vaccinations, pre-exposure prophylaxis, bactericidal products, and of course information, we gain a lot of knowledge which could lead to a better use of these primary prevention programs to tackle STDs. Here you see a graph of Australian-born women in 3 cohorts. Cohort below 21 years in light blue, and then 21 to 30 years, and above 30 years in the darker colored lines. And you see the effect of HPV vaccination on the percentage of genital wart diagnosis. And you see that in the cohort that has been vaccinated, the below 21 group, you see a dramatic decrease of 10% to below 1%. So it is feasible, if there are STDs vaccines available, to have a tremendous effect on the incidence of sexually transmitted infections. And this is also something coming from Australia, where the group of Kit Fairley has looked to oral gargles and rinses against gonorrhea transmission in the Omega study, where men were given Listerine to see if it can reduce the number of gonorrhea, pharyngeal gonorrhea infections. And he sees a big role of oral sex in gonorrhea transmission. In the United States, there is a group called the Microbicide Trials Network who looks at preventive measures through douching, which could have an effect on anorectal gonorrhea infections, which is the location of most diagnosed infections in men who have sex with men. Point of care testing, of course, is also something which could help a lot. If you can provide a test within 30 minutes, people are far more receptive for counseling. You can break the chain of transmission instantly. No-show problems are something of the past, and it's highly efficient. And we already have point-of-care tests when antibody tests can be applied. For example, in the case of systemic infections like syphilis, HIV, and hepatitis B and C. For chlamydia and gonorrhea, we now have tests which can deliver results within 90 minutes, but we're looking for the line of new platforms which will deliver tests in a shorter period of time. The big problem, of course, for the next 10 years is also antimicrobial resistance in gonorrhea, as I already mentioned, and it's considered a top priority for WHO. And a lot has to do probably also with the loss of susceptibility testing, which is becoming exceedingly rare since it's been disbanded for nucleic acid amplification tests. If you want to have a viable culture, which you need for susceptibility testing, you need same-day sample transportation, and the results before the tests, the susceptibility antibiogram becomes available takes days. There was a very good modeling study from the group of Fingerhood, who modeled what the effect is of nucleic acid amplification tests and also point-of-care tests for gonorrhea on the induction of antimicrobial resistance in gonorrhea. And WHO recommends to disband an antibiotic for indication as soon as more than 5% of the strains which are found in a population has become resistant for that particular antibiotic. And in the time when culture was still used for diagnosis, you see that that was reached between 20 and 30 years, the level which is indicated here in the striped bar. Now we live in the time of nucleic acid amplification diagnosis. You see that antimicrobial resistance is induced far quicker. In blue, it's indicated in an MSM population, in green, in a heterosexual population. It takes a matter of years to reach unacceptable high levels for the continuation of that particular antibiotic. And if you have point-of-care tests in the future who do not have these, tell you anything about antimicrobial resistance, it won't affect the speed in which antimicrobial resistance is induced. Only if point-of-care diagnosis with resistance determination become available, you will be truly able to impede the induction of antimicrobial resistance, as seen here in the top of this figure. Lastly, shortage of out-of-patient antibiotics could become a big problem. There is currently a shortage of benzathine penicillin G, and this has to do with the small profit margins and the high production cost of parental drugs, which leaves only 3 factories allocated all in China who produced it up until recently, when 2 discontinued the production because of regulatory and environmental issues. Penicillin G is the only safe option for pregnant women to prevent congenital syphilis. And since the availability has been threatened, WHO now indicates a public-private program to ensure quality, safety, and efficacy standard. What we've seen recently in the Netherlands is a confusion, not only among general practitioners, but also among pharmacists between benzathine penicillin G, which is a long-acting penicillin, and sodium penicillin G, which is a short-acting variant, which is given out because of the lack of availability of the benzathine penicillin G. And of course, this doesn't help, and we see treatment failures for that reason. So to conclude on STD control in the coming 10 years, the HIV goals seem realistic, but it doesn't apply for the STD targets which have been formulated. STD testing policies could be more focused to stay away from the danger of antimicrobial resistance induction. And we should reconsider asymptomatic infection screening in favor of infectious disease control. Screening frequency also, do we need to screen in the absence of complaints every 3 months, or should we find other ways to fight STDs, for example, in the form of vaccinations, biomedical interventions against STD? And we should invest in antimicrobial treatments, develop new antibiotics, and also keep the out-of-patent antibiotics that we have available for the coming period. And this last slide is dedicated to a conference that will be organized together with IUSTI and ISSTDR in 2021. With or without Corona, we plan to have a hybrid conference with either physical or virtual attendance possibilities. Thank you for your attention.
All right, thank you, Dr. DeVries. That was similarly amazingly helpful to us. Thank you. We're now going to hear from Doctors Meg Doherty and Melanie Taylor, who are from the Department of HIV, Hepatitis, and STI at WHO, somewhat recently reorganized department, and Dr. Sammy Gottlieb from the Department of Sexual and Reproductive Health and Research at WHO. So thank you for joining us on extraordinarily short notice, and please feel free to start your presentations.
Okay, thank you very much. This is Meg Doherty. I hope you see the presentation in full view. Is that correct? Just want to check before I get started.
Yep, all good.
Okay, thank you. And I think I should just have to say thank you and right up front and say this is the collaborative effort of slides that have come in from Melanie Taylor, Sammy Gottlieb, Theodora Wee, and Natalie Bruet. And I think why I was asked to make the presentation is it's to reflect a bit of a change that's happened at WHO. And I'm just going to have 2 or 3 slides around some of the changes we've had, but in many ways, I think these are great opportunities, and I'm so happy that I have the chance to present, and then the real experts will correct anything that I get wrong. But for those of you who don't know me, I'm Meg Doherty. I am an infectious disease physician and clinician and epidemiologist who has now been at WHO I'm in my 7th or 8th year at this point in time. And most recently, in the last 3 months, have become the director of an expanded department. We are now the Department of Global HIV, Hepatitis, and STI programs. And to link back to the first presenter, this is sort of an expansion of our 3 interlinked global health sector strategies. And in so many ways, I know a number of you from a previous lifetime, and it's great to see that we can see how we can find the synergies between the HIV programs, what we learned from scaling up hepatitis programs, to the STI program as well. And program is really important because it reflects the need of getting impact to country level. And I think at WHO, it's been a tiny but very mighty team that has been working on STIs, all of 5 people for the entire global STI program. And now we're trying to expand to be able to have a greater country focus and impact focus. Just to know that if you're following the World Health Assembly at all, you may know that we're now working under the global program of work where we have 3 billions or a triple billion target. And our work on communicable diseases sits under the first billion of people with better health coverage or universal health coverage. And we're aiming to reach these targets and all of the targets that are embedded in the SDGs, or the Sustainable Development Goals, by 2030. So we're guided by quite a bit of, one might say it's either bureaucratic or strategic approaches. And so in many ways, it's more about trying to fill in the dots and ensure that we have the right information to be able to drive that impact at country level. And just to say, this is the important sort of, if we had to say, theory of change behind bringing together the departments and how we're addressing reaching impact at country, is that at WHO headquarters, we're focusing on the global goods. What are the new guidelines, the new standards, new drugs, new diagnostics that we can then use to drive country impact? And also, what are the global leadership goals that we need? Are we advocating enough in a global scenario to ensure that all countries, all partners, all civil society and others are actually working with us to drive that impact? So let me get to the meat of the matter. This may be repeating a bit of what other presenters have shown, but we are highlighting the most recent data that are coming out of WHO. And so you probably have heard that the most recent reports that came out indicated that we have more than 1 million STIs acquired every day. And that's enormous. And when I brought that number to the Director General just recently, I think it just dropped their jaws. They had no idea the enormous burden. And this is just for the 4 curable: chlamydia, gonorrhea, syphilis, and trichomonas. And of course, this is affecting the regions of the world with the least well-developed health systems, such as in sub-Saharan Africa, as well as in Asia. What we do know, if we start then to add in the viral infections, and Sammy just put out a wonderful new estimate paper in the bulletin showing that we have 500 million globally people affected with genital herpes. And if we take that to all herpes, we're at billions. And we have 1 in 7 women who have a prevalent HPV infection. So in general, we have an enormous burden, and we may not have all the systems in our high burden countries to address reducing that and improving the quality of life, but reducing the morbidity and the mortality. So here are some of the outlined adverse health effects, both sexually and on reproductive health. We have a major flagship coming out of the WHO regarding HPV. We have over 500,000 cases of cervical cancer annually, and we have a way to address this. We know that syphilis can lead to, and mother-to-child transmission can lead to greater than 200,000 fetal or neonatal deaths per year. In terms of infertility, gonorrhea and chlamydia are major factors in association with increased infertility. And we know that STI, HSV2 in particular, can travel with HIV. So if we can address HSV either through vaccine or treatment and reducing the infection and the open wounds, we can actually, we hope, in some form or manner, reduce some of the HIV risks as well. And we know this has an enormous effect on quality of life. This I believe others have spoken to, but just to note that we have a program through the WHO Gonococcal Antimicrobial Surveillance Project, or GASP, which is similar to the US eGASP, where we are looking at both decreased susceptibility and resistance to the extended spectrum cephalosporins, including ceftriaxone and cefixime. And what you can see is that we're starting to see countries around the world with increasing rates. And these are the kinds of data that we need to follow over time to ensure that when those countries hit that 5% mark, as was mentioned by the previous speaker, that we have an alternative regimen and an alternative approach to offer people who are suffering from gonorrhea. This is just an outline of our global health sector strategy on STIs. And we're working under this from 2016 up to 2021. And we're in the process now, already in 2020, to look at how we can extend and expand the global health sector strategy. But what's important is we have 5 common and interlinked strategic directions for HIV and hepatitis and STIs that focus on good information, that focuses on interventions for impact, meaning that we have priority public health goods that can address important interventions, that we're delivering for equity at country level, that we have financing for sustainability, really thinking about how we're going to integrate these programs into a universal health coverage program, and looking for innovations to help drive that. And I think all of these areas, I'll speak to them in just a moment, are the areas where if you wanted to think about where we need to invest, these could be the areas that we can invest in, or we can look to how did hepatitis start with very little funding, but including these targets and these approaches within their universal health coverage and primary care programs in various countries. So driving action at country may be a different view or a different vision than a very top-down approach that we've seen with HIV. Although there are opportunities to build upon the HIV platform and see if we can expand. So what I did want to highlight here, and you can look at this at leisure afterwards because it is quite busy, but I think the areas in red are the areas that I think sort of speak to your needs. How do we deliver in country and do this equitably? And what was brought up was building upon the PrEP programs, building upon the mother-to-child programs, adolescent and family planning programs, and ensuring that we have adequate STI testing, treatment, and involved in reducing the vulnerabilities and focusing on key populations. I think what we realized in HIV and even in hepatitis, we have a very strong civil society and commitment from civil society and healthcare workers to ensure that they're testing and treating for HIV and hepatitis. We have to do the same for STIs. And we have to have access to quality commodities, because I think the supply chain has been one of the biggest chinks in the global public health that we've seen with COVID, and we have to strengthen that for STI as well. And the other area where I think if international groups want to make a real impact quickly is to look at the areas where we can accelerate innovations, either optimizing vaccine. We had a wonderful vaccine PCC discussion about how can we move forward and put up and prepare for a terrain for both gonococcal vaccines and other vaccines. We have point of care tests that we need to get from, say, the research area out to countries and paid for and implemented and used. We know we need to have a longer pipeline of new treatments coming through. And what we haven't done necessarily with STIs is really map where are the best places to deliver services. It may be that PrEP is one good place, but there are private sector, and we know that pharmacies. So how do we map in each context to ensure that we can reach the most people and also do the partner tracing and ensure that partners get treatment? So in our global health sector strategy, not to bore you with our impact indicators and service indicators, just to say we have them. They're very ambitious. And what we've started to do since STI has joined the department is really map out what are the countries that overlap with HIV and hepatitis programs, where we can build upon what platforms are there, and where are the countries that have incredibly high burden that we have to either build or build upon another series of public health interventions that are in the country. Just to say, we are in HIV, we can usually say that we're getting close to 90-90-90, you heard from the other speaker. But when we think about the target setting and reaching the targets for STIs, we're in the single and double digits in terms of performance. So we have a long way to go to increase A, reporting, and B, ensuring that that reporting covers all areas. So this is the greatest that we've had is now that we have countries reporting on an STI action plan and reporting into what we call the global AIDS monitoring. And that's great, but that's primarily for syphilis. And we need to expand that to the other curable STIs and the other STIs such as herpes and the viral STIs that really need to have a champion out there and that we need to be able to monitor. So one priority for WHO is really strengthening our M&E system. It doesn't mean that it's all bad. We can say that through the excellent work of Melanie, she has been pushing and pushing around reducing the mother-to-child transmission of syphilis. And we have an approach called a certification for validation of elimination of dual HIV and syphilis elimination. And I think that that package has been able to bring people around ensuring that we have coverage for low and middle income countries in the ANC package, so syphilis is tested, that screening leads to treatment, but we still have areas where we're still seeing neonatal deaths and prematurity and low birth weight and missed opportunities where the screening has been done, but the treatment has not been provided. So having some standards and some acquisition of WHO validation of elimination has really pushed a number of countries to try to achieve this elimination target. And that could be done for other STIs. Now, just in the last few minutes, I wanted to highlight a few of the important pieces that have happened since 2019 in WHO that could be used as we are starting to scale up activities in countries. We have made a new recommendation that looks to use a dual syphilis screening test for HIV and syphilis. And I think this helps because if we can implement that within the PEPFAR programs, within Global Fund programs, we can really reach identification of mothers who have syphilis. We are looking at, there's been quite a bit of work done on reducing the global shortage of penicillin, and Melanie is running a trial to be able to look at alternative treatments in pregnancy. And this validation of elimination I spoke to, but now we've added hepatitis B as well to sort of push that agenda. And that is an STI, so I think it's worth keeping in there as well. For reducing cervical cancer, we're being guided by a number of very ambitious targets, but we know if we can achieve them, we can eliminate essentially cervical cancer by the end of the century. It's a long way out, but if we can have 90% of girls with HPV vaccine, 70% of women around the world getting an HPV screening in a lifetime, and 90% of those treated appropriately, that's always the most difficult. But if that can be done all together, then we can really eliminate the cervical cancer. And we will be coming out with new guidelines for both screening and treating for women living with HIV and for women in general this year in 2020. For the gonorrhea the Neisseria gonorrhea that is resistant in the AMR, we have a lot of emphasis right now on reducing and ensuring that we have options for antimicrobial resistance. And we have a global action plan under which to work. We have programming. And I think the most exciting is that WHO has been working with GARD-P on new gonorrhea treatments that are going into clinical trials very soon, as well as an approach to point of care gonorrhea testing using NAT testing so that we can quickly identify drug resistance and ensure that persons who need it get the right drug. And we're facilitating the vaccine development. I think this would be of interest, and maybe it's not up to date, but excuse me if it's not, for Charlotte Gatos, but just to know that it's like the HIV pipeline of new available tests, that it gets very, it's very thin, and suddenly in 2019 and beyond, we hope to have multiple point of care or near point of care that can use nucleic acid testing so that we can have gonorrhea, GC, and hopefully others, chlamydia, gonorrhea, and hopefully others in the future that can be done on rapid testing so that we can get that back for low cost in low and middle income countries. And there's at least 8 what we call TPPs out for countries to be able to start manufacturing. And certainly these kinds of innovations are brought through WHO relatively quickly so that they can get to countries at low price. And Unitaid group is quite interested in seeing how we can push and challenge that for country implementation. There is also, Sammy has been working on STI vaccine roadmap, and this collaborative effort has really brought to the fore what are the kinds of vaccines that we need to focus on, and most recently are focusing on the gonococcal and the HSV vaccines. And I think this is an important piece for the prevention that was brought up earlier in the discussion. So in summary, we have lots of challenges to STIs in the control, and certainly we have had a lot of wonderful research, and now we want to bring that research to country to really have the impact across all of these areas that I brought up. And I think it's important that we not forget that we have competing priorities, and usually STIs does not float up to the top. So it's about advocacy and how do we bring this up to the top. So some of the challenges that we are planning to take on in this year is looking at our under-resourced STI interventions. And what's important is that we have good data, and we're trying to strengthen our data, strengthen our national data, and we're also looking to how this can be brought into what we're calling our UHC framework for data as well, and into what we call the DHS2, where that data can be collected in the countries. We have low STI service delivery and low capacity, so we want to be able to provide more technical support. We want to make the economic case for other donors why this makes sense, and we're working with the Global Fund and Unitaid to say, especially like in PrEP clinics or for key populations, that we need to do this, or for adolescents that we need to do this, and how do we integrate. And really exciting is that we're looking at ensuring the availability of new medicines, certainly benzathine, and also bringing the point of care diagnostics to sites. So the Director General asks us to follow all of our programs on 6 pillars. And I would have to say we've done very well on leadership and global guidance or global goods. Some need to be updated, but it's been a very rich global good area. We have to do more technical support at country level, but where we really need to be focusing over the next couple of years are achieving country impact and ensuring that we have a way to have value for money and to have a financing for this, whether it's integrated into UHC or finding new donors or finding cheaper ways to deliver STI treatments and testing treatments and care. So with that, I'd like to finish and thank all the people who brought these slides together. But I think what WHO is very eager to do is to look at all the research, look at the research priorities that you may develop either through NIH and others, and understand, are these research priorities actually going to make an impact at country? And are we prioritizing over the next 4 to 5 to 6 years on scaling up the programs in country? So we look forward to working with you on that. With that, I thank you and I close.
Thank you, Dr. Doherty, much appreciated, and also your colleagues, Drs. Gottlieb and Taylor. We now have 20 minutes for Q&A with all the speakers and the committee. So please raise your hand on Zoom, committee members, or type your note on chat. And as you're doing that, I'm going to ask a quick question. Primary prevention, if we borrow the 20-year-old, 30-year-old HIV strategy of ABC, abstinence for our youth, being faithful, reducing partner numbers, and condom use. You don't hear much about ABC these days. You could even add a D, which is discouraging douching for women. Where does primary prevention fit in the paradigm of STI control? Have we sort of thrown up our hands and decided to focus on case finding and treatment? Question for any of you.
I think it would be, from the WHO's perspective, it would be great if Sammy could take that on, because we are prioritizing certainly not ABC, but vaccines. And I think that's one area of primary prevention as well, rather than just case finding and reducing others through treatment. So Sammy?
Yeah, well, I think in the realm of thinking about new biomedical primary prevention technologies, I mean, I think there really has been a big effort from the, and a big collaborative effort, both from the US, from NIH and CDC, and kind of global technical partners, on really thinking through how we can advance this agenda related to STI vaccines. And I think there's been a lot of promising movement on that recently, particularly related to gonococcal vaccines, with very encouraging findings that meningococcal serogroup B vaccines might provide some cross protection for gonorrhea. And so a lot of work around that to see if we can advance development of those vaccines. And also quite a bit of work with several candidates in early clinical trials for HSV. So I think that in terms of biomedical primary prevention, there's been quite a lot of work, and we've seen through the efforts with HPV vaccine that it can be very effective. But Sted, I'm not sure if your question was more around the other types of primary prevention in terms of you know, comprehensive sex education and condom promotion and that kind of thing. I mean, I think this is where, you know, we're really needing to find a balance at trying to implement those within existing programs. And I think there's a lot of opportunities with that, with some of the things we've discussed, like PrEP. But I think it's becoming a little bit more difficult in the era of a whole host of biomedical prevention measures for HIV. And I welcome others' input on that as well. But I still think it's a focus, and it's an important focus, and we shouldn't forget about those things. And we're trying to incorporate the you know, measures for adolescents in terms of comprehensive sex education across many levels, and how we can build on, for example, adolescent platforms for HPV vaccine delivery to provide other types of primary prevention. So I don't think it's been forgotten, but kind of in tandem working on some of these biomedical primary prevention measures for STIs.
Thank you. Henry, do you have anything to add?
Yeah, I think ABC and especially condom use was highly effective in the age when HIV was still a deadly disease. After 1996, when antiretroviral therapy became available, you saw an increase again of bacterial STIs that probably had to do with less condom use in the face of the changing landscape of HIV with the introduction of antiretroviral therapy. What happens at this moment is that the newer forms of primary prevention, as was already mentioned, like for example, pre-exposure prophylaxis, are put into a bad light, as if the rise of bacterial STDs that we see at the moment is caused by these biomedical intervention, which leads to less condom use. But what I think is that people already abandoned condoms long before the arrival of pre-exposure prophylaxis. So I also agree we should focus more on biomedical interventions. Also in the history, vaccines have proven to be highly effective, far more effective than trying to have people change their behavior. To try to change sexuality is a very hard thing.
Thank you. Janet, I'm not seeing you're unmuted, so maybe should we go to the next question?
Yes, I don't think I have anything to add to what's already been said.
Great. Okay, I'd like to call on Kay's next.
Thank you, and thank you to the speakers for their presentations. I think very insightful and helpful to our process. I actually wanted to follow up on what Henry was just saying, and actually sort of reflecting a little bit also on a paper, Henry, you wrote with Ken Mayer a couple of years ago in the Journal of the International AIDS Society, where you talked basically about the fact about this sort of uncoupling of the not only of the epidemiological synergy between HIV and STIs, but also an uncoupling of HIV and STI prevention. Whereas, you know, before treatment, and you're right. I mean, this has been happening for a long time before PrEP. I mean, this has been happening since the mid to late 90s. When before that, HIV prevention was very much with STI prevention, of course. Now we're looking at an uncoupling of these two, and you're talking about a new normal that is emerging, where we have to deal with this new sort of reality. Of course, new normal is a very you know, that goes very quickly. The new normal now is now COVID. So I guess this is the old new normal. But I still want you to sort of push it, because I think this is probably the most relevant sort of place where the epidemiology and the resurgence of STIs in Europe, as well as other parts of the world and America, are sort of very similar, if not the same, because they're all related to the same thing. And so I think that's one very important place where we're kind of struggling as to how we move forward in sort of acknowledging the importance of what's happening in the HIV world, and still, you know, wanting to deal with what's happening and you know, having worries about this new normal, where we're basically saying, well, you know, some of these STIs, they're just going to be with us, and as long as we test and treat, it's going to be okay.
Anyone want to respond?
You're muted, Henry.
Yeah, I agree. I think, well, first of all, I think you should realize that we talk about a focused epidemic. Also, as far as STDs is concerned, at least in the high income countries, it's a focused epidemic. So I think that's an opportunity as far as bacterial STIs are concerned. That it's mainly taking place at this moment in men who have sex with men, and they form a separate transmission network from the heterosexual population. So that could help to tackle the decoupling that we see at this moment. For example, in the form of biomedical interventions that, of course, need to be developed. It's a completely different picture in low and middle income countries, where you're faced more with a generalized epidemic, also where bacterial STIs are concerned.
Let's go to Patty's question.
Great, thank you so much for really great talks. So we are charged with updating or redoing the hidden epidemic, which is about 20 years ago. And so STDs have been increasing in the United States and actually kind of worldwide. And I just wanted to see, what's your opinion on why they're increasing, And, you know, I don't know if you can give us advice of what you think is like the top things that we should do. I know, Henry, you talked about you don't think that PrEP was the culprit, but I was just curious as to our charge is to figure out why STDs are increasing so much and what we can do about it. And I just was interested in your advice. Thanks.
Yeah, as I already mentioned, the thing is, a lot of the patients that I see do not consider gonorrhea or syphilis something very serious. It's something that they take into account, just like driving a car without wearing your safety belts. So this was different, for example, when hepatitis C hit the MSM community in Western Europe. There was far more concern because back then it was still a chronic disease. So I think these incident infections are taken not very serious by a lot of people who form the core group of transmission. So that's the difficult part. It's probably also something that takes place during a certain point in your life, a phase where you go through, where you have multiple sex partners, which leads to the contraction of STI. But that's also something that people phase out of when they get older. So if you can identify the population that is most at risk for bacterial STIs, and that's probably the very young population, and target those individuals with primary prevention efforts, that would be effective. The thing in the MSM community, what we see in Amsterdam is that it's not only very young persons who have multiple STIs within 1 year, but it's also an older group, which was also mentioned by Janet, for example. We see a lot of chemsex use of substances which lead to disinhibition during sex parties. And this is also, it's not only young people, it's also an older generation of men around their 40s, for example, who are at extremely high risk for bacterial STIs, who already are HIV infected and hepatitis C infected. That's probably the most difficult group to target and have their risk behavior changed. I think a lot of effort should be put on other primary prevention efforts apart from the ABC that have been mentioned before.
Thank you. I think you have a response as well.
Yeah, I just wanted to quickly say what we've learned from the HIV. It may or may not be fully applicable, but we need to investigate. Is that there is with the U equals U, this sense that one would need that one doesn't need condoms anymore in some cases if one is virally suppressed with HIV. And the other thing is we're just seeing less condoms around, that we have stockouts. And so even if people do want to use condoms, they may not be available. And I also think that, Melanie may want to speak to the fact that we have stockouts of medicines. So, if we don't have the right medicines in the right place, obviously this is going to contribute to increasing incidence if we're not able to control this with the drugs, and or if the testing is not happening. And I think we also need to think about the resistance, but I don't think that's necessarily driving the incidence so much, but it could in the future. But perhaps Melanie wanted to speak to at least what we see in increased incidence.
Yes, thanks, Meg, and thanks, everyone. I'm Melanie Taylor, worked with Meg at WHO on STI surveillance, but also addressing some of the medication shortages, and have focused over the last several years on benzathine penicillin shortages. And I will say that the global supply of benzathine penicillin for the moment is back on track. All three manufacturers of the active pharmaceutical ingredients are producing at the rates that are required based on the demand, not only for syphilis, but also for rheumatic heart disease. as well as group A streptococcal infection, yaws, and some of the other soft tissue infections. The threat, however, to having a sole source of one country producing benzathine penicillin is continuing. And there are real concerns about having this as the only recommended therapy for pregnant women. And so we really need to look into alternative treatment specifically for syphilis, but also as we face the threat of other medication shortages, even due to COVID-19, such as azithromycin and cefixime, when we are now reverting back to somewhat of a syndromic management picture, as I understand in the United States, we really need to address the fact that our commodities of medications are at risk. And then just to say regarding the challenges of prevention, that we are facing a bit less than what you're probably challenged with in the United States at this moment are the ease of soliciting sex partners. It's a bit like using online ordering now, whereas you can order sex online, you can't necessarily order a test or treatment online. That still requires you to address or to attend some type of clinical visit, whereas the ease of acquiring sex and the risk of having unprotected sex is much easier, much faster, and much more, I would say, facilitated by the online experience and web and phone apps. And so this is something that probably is much more contemporary than would have been addressed in the hidden epidemic 20 years ago, and has really fast forwarded all of the interventions, but not at the speed at which people can acquire sex and have unprotected sexual activity with numerous partners. And this is a new generation of phone texters and users of these phone apps to solicit sex. Over. Thank you.
Thank you. Janet?
Yes, I was going to come up with a different suggestion. Obviously, our diagnostic techniques have improved tremendously, and now with the nucleic acid amplification tests, we're able to detect very low-level bacterial infection, and we're advocating rapid retesting every 3 months for adolescents and MSM. And maybe we are creating a problem because perhaps some of these very low-level bacterial infections would be resolved spontaneously by the person's immune system, but we are now detecting them and then treating them with antimicrobials. So I think we perhaps do need to think, how often should we test people? I think Henry's idea of obviously we're treating asymptomatic infection to prevent sequelae, but by doing that, are we actually creating more problems?
Thank you very much. We are a little bit over time. We have 2 more questions from doctors Charlotte Gaidos and let's see who, Patty Kissinger, no,
Carmen Zaria.
Carmen and Charlotte. I have a hard stop. I'm going to say thank you to our guests, but ask everybody else to stay on for another 8 or 9 minutes to get these last 2 questions in. So I want to be.
If that
we'll have,
do you have a few more minutes?
Comments.
Okay. I have 2 questions. One for Janet and for Sammy, more or less related. I'm an OBGYN, so certainly syphilis in pregnancy and HIV are part of my passion and my interest. And you talked about, Janet, you talked about STI care teams. And Sammy, you talked about the dual rapid HIV syphilis testing. I do have a scenario like in the US, there's many places where there are pockets where the prevalence, lack of resources resemble low-income countries, even though they are just pockets. In addition, we have different sources of STI funding. So how can you recommend we accommodate that? For example, I think it's fantastic to have HIV and syphilis or STI treatment teams. And the co-testing, the point of care testing, I think it's also something that we would love to have available in the US. Any suggestions?
Perhaps I can address the question on the rapid dual test for HIV and syphilis. Sammy, does that work or okay? Yes, this is Melanie. I would just like to say thank you for your question. It's really excellent. And what we have found with the rapid dual test is that because it's an HIV test, oftentimes the funding can come from HIV, recognizing that populations at risk for HIV are also at risk for syphilis, and having a dual test is also something that can really optimize antenatal care screening for both infections with a single finger stick. And so we have been fortunate to have the interest of agencies like PEPFAR, like Global Fund, and like some of the other funders and stakeholders that are invested in HIV, but recognize the synergy with other STIs, such as syphilis, in facilitating HIV transmission, but also in recognizing the co-transmission in key populations and the tremendous risk to unborn infants. So that is one of our experiences here at WHO.
And I would agree with that. I mean, presumably you have HIV teams, HIV midwives who work with your pregnant women. These our midwives were initially funded through our HIV services, but now they've taken on the role of both syphilis and hepatitis care as well. And we use exactly the same obstetricians, pediatricians who are there to deliver the HIV care, but they now also deliver the syphilis care as well. So I think you can use what is currently available for your HIV service and extend that to your syphilis service as well.
Thank you. Carmen, did you have a second question, or did you ask it already?
No, they were combined. Thank you so much.
Okay, sorry. Thank you. Okay, let's go to Charlotte's question, and then if we have time, we do have a question from Sean as well. So Charlotte.
Thank you very much to Janet and Meg and Henry for excellent presentations today. I am so happy to see that people are becoming interested in point of care tests. But my question is, and I want to phrase this correctly, but clearly the United States is far behind the UK and the Netherlands, and may well be behind WHO in the near future with what we're doing to control STIs in the United States. And I wonder if each of the speakers could make one short recommendation of something that would help the United States end this pandemic. Just very quickly, what do we need? What's our recommendation? Thank you.
I think my recommendation would be that some organisation, presumably it would be CDC, needs to decide what is the minimum STI care that should be provided to the population of the US, and that has to be funded to everybody.
I think Meg has a response.
Yeah, I was about to say the same, maybe in the light of what's happening in the United States with COVID, to say there's an enormous tradition of our public health system and our local city public health being very strong in STI care and, case finding and treatment, and I think refunding, and perhaps if there needs to be ways to reduce costs, looking for the approaches where it could be, formulaic with reduced costs of testing along with that.
Thank you, Henry.
Yeah, I'm not completely familiar with the way financing of public health efforts is taking place in the United States, but if you could make a case for private health insurance companies, the importance of having access to STI care, not only for their participants on their programs, but also for the partners of the participants who are not paying their fees to these private companies, they might be willing to have some form of financing STI basic care, even for undersecured persons, because in the end, it will increase their burden, the burden of STI care, if it cannot be provided by the government itself.
Okay.
Thank you.
Oh, go ahead. Oh, thank you, Charlotte. Okay. Sammy, did you have a response to that as well?
Yeah, I just wanted to add, I mean, I had put my hand up before and really wanted to echo what Meg was saying about, I mean, the US has had a tremendous history of, even with the bacterial STIs, at least for gonorrhea and syphilis, seeing with just intensive basic public health measures of identifying people with infection and contact tracing and kind of teams of local and state healthcare workers and contact tracers really seeing a dramatic drop in those infections. And it's just in recent years that we've seen those go up. And I think obviously there are multiple factors at play, but so I think that yes, to echo, you know, as kind of STIs are kind of a harbinger of the health of the public health system. And so of course with COVID, you know, kind of reinforcing that we need to re-bolster that system. But I think also in parallel, because of some of the other things that have been brought up, what Henry was saying earlier in case, that we need to in parallel invest in some of the innovations like STI vaccines and kind of biomedical primary prevention measures at the same time as bolstering our current kind of basic fundamentals of public health response. Thanks.
Thank you. So I'm going to push my luck a little and ask Sean to ask his question. It does build a little bit off of what you were just saying, Sammy, so in a different angle. So Sean, do you want to ask your question? And then I promise we'll let you all go.
Yes, thanks, Amy, and thanks everyone for great talks. So question is around how COVID has affected use of digital tools and public perception of digital tools, which have typically been issues of privacy and confidentiality. So what I'm thinking is around contact tracing, for example, digital contact tracing, and there's been push actually against having more privacy in public health, often saying we need things that have traditionally been more invasive. And I'm wondering if your thoughts on this and if it will spill over longer term into STI surveillance to be able to use contact tracing apps, for example.
So we have been using contact tracing apps for STIs in the UK for a while, but I mean, it's a bit like the COVID apps, that it's reliant on the person downloading them and then using them, and they are particularly popular amongst the MSM. Historically, we've always found, particularly heterosexual males, very difficult to get partner notification details about. But my view is that I hope that the pandemic will indicate and identify to people just how important contact tracing is, and that hopefully we will see them a little bit more amenable to giving us and sharing with us their information about their partners, whether that be using a digital method like an app or the traditional sort of face-to-face methods that we've used in the past.
Yeah, I also see a great opportunity to use apps for contact tracing. We have a website in the Netherlands where patients who have been identified as index patients can send messages to their partners. And if you compare it to COVID, it will be a lot easier. I mean, you don't have to rely on Bluetooth to estimate who might have been infected because it's an airborne disease. STDs are only passed on via mucosal contact, and people know exactly when that has occurred. So I really see a great opportunity. And as a previous speaker also said, sex is very much available in the virtual space, but all the things you need to prevent STD spread are still underdeveloped. So contact tracing is really something, is really an opportunity to fight STDs in a virtual environment.
Thank you. Meg, I see you have a response.
Yeah, I could just say that, you know, of course, the United States is slightly different than the rest of the world right now in terms of acceptance, but it feels, looking around the world and low and middle income countries, that some of these apps and some of these electrical, or digital solutions are really being taken up. And there's maybe less concern about privacy. I do think that we can look to the testing world of HIV, where we do have digital approaches, self-testing, getting results back digitally, and lots of examples of assisted partner notification and network notification, where some of this is moving into the digital sphere. I think the challenges always are in, making sure that people are protected, and when they want their privacy protected, and/or there aren't untoward effects related to either inter-partner violence, etc. But I think outside of, many places, I think this is a great opportunity, and I don't know if Sammy or Melanie would like to speak to it, but I think we have a lot of lessons learned from the HIV testing world. Over.
I don't have anything to add, but.
Yeah, I agree. I don't have anything to add either.
So as happens in this COVID world, things are always changing. And I did say I would let you go, but I am hoping Ned Hook had to step away for COVID-related work, actually, and he's back from member of the committee. And he has a pretty straightforward question for Henry and Janet, and I think maybe they could give one-line answers, and then we can go. So Ned, do you want to ask your question?
Well, I can't ask it as a one-line question.
Well,
so my question is for Henry and Janet and Sammy. I'd welcome your thoughts as well. You're all coming to us and sharing your knowledge and expertise from environments where the way healthcare gets paid for is very different. And what I'm wondering is, even in those settings where you have much more far-reaching health insurance, are there situations where patients prefer to go to private providers for whom they pay a separate fee for their sexual health care services? I think, at least here in the United States, I think in some instances that relates to issues surrounding stigma as well as payment situations. So love to hear your thoughts and comments.
Okay, is there something to add?
So Ned, absolutely. We do have people, a number of private providers of STI services, and obviously they're only there because a number of people choose to use them, even though they could go to our standard STI clinics and get the same service for free. It could be about stigma. A lot of it is about not wanting to be seen. They may be famous. There may be other reasons they're not wanting to be seen in a public STI clinic. So I think it's important that you have both of those services, because there'll always be people who want to use those private services as well.
Yes, in the Netherlands, we have also an increasing number of private services for STD screening and treatment. And that probably also has to do with the fact that the demand is exceeding the availability of testing free of charge. What we found out in the COVID period, for example, is that we now only see patients with complaints, and we see a whole lot more syphilis at this moment compared to the pre-COVID area. And that probably has to do with the fact that people had to wait for at least 7 days before they could get access to the clinic, even if they had complaints. And now the waiting period is down to 1 or 2 days, because we only see those with complaints. So even in the Netherlands, where it's free of charge, there is absolutely a market for instantaneously accessible care.
That's very helpful. Thank you. Thank you both. I don't know if Sammy or Meg have a comment on that or not.
I don't really, I mean, other than there are so many different systems and contexts, and just how important it is to kind of gauge and guide, like, you know, really getting the data on what the needs are of people who are using the services or who would like to use the service, and figure out how that, the interplay of those needs with the systems. And so I think for every setting, it's very different, but in the US, it may be a little bit more complicated than many because of kind of the fractured nature of the different services. But I do think this is something important to have this kind of option. And I think really getting better data on what people need and expect from STI services, and how that can best be integrated with the systems that are in place in a particular setting are really important. Thanks.
I would just have to add, from living and working in low and middle income countries for about 10 years or more, that STIs are primarily taken care of in either the private sector or, you know, or pharmacies. Because when people have symptoms, they go to the pharmacist as opposed to going to a clinician or a clinic. Because it's easier, they're open all night, and antibiotics are cheap, over the counter, etc. So I think when you think, I don't know if you're only thinking about the United States, but if you're thinking about how to adapt some of your thinking around the global goals, it definitely has to take into consideration a public health, a public health setting, a private setting, as well as pharmacies and other providers of care.
Thank you all.
Yes, thank you all. So I know Stan feels terrible that he had to step away, but he had a hard stop. And so on his behalf, I just want to thank all of our speakers today, especially given the late hour in your respective locations. I believe I speak for the entire committee when I say we are eager to continue their work on these important topics that were discussed today. If you have any comments or questions, please feel free to send them to me. You can also send them to stiprevention@nes.edu. Please keep in mind that any material that's shared with the committee is made public through the project's public access file, which must be done because the National Academies complies with Section 15 of the Federal Advisory Committee Act. And with those comments, I just want to say thank you again, and we can adjourn this meeting. Thank you so much.